We'll just start. Thank you. Some opening notes and reminders. We're so glad if you've been with us before and are joining us again. And if it's your first time, we'd love to meet you. So please type your name in the chat and where you're joining from. We're very fortunate to have Dr. Suman Jayadev speak to us today about neurogenetics and clinical care, a very complex and important topic. And we'll have plenty of time for discussion at the end. So please put your name, identify yourself, name and clinic. If you're not speaking, mute yourself. We'd love to see if we can. We understand if it's not possible. And if there's a couple of you in the room, then please list those of you who are joining in the chat. So CME accreditation for everyone is possible. And for those from the University of Washington, either faculty, staff, or students, you can register via this mobile text registration and sign-in process. If you haven't registered, you can send your UW email address to 833-394-7078, and you'll receive a response stating that your number has been updated. And then you can text this 10085 to the same number to register and receive CME, to register that you attended and to receive the CME. And you should receive that confirmation. For all of the other attendees, Sammy can record that you've been here, and then the Zoom analytics as well can track that for you. There's a number of fantastic other University of Washington Project Echo programs to deepen your knowledge in other areas, such as in geriatrics and traumatic brain injury, in addiction. There's a telebehavioral health training series as well. Additionally, there's a fantastic telephone consultation line that you can call and actually speak to a pain and addiction specialist through the UW Pain and Opioid Provider Consultation Hotline. And this is particularly for those who have high-dose opioids and complex pain medication regimens. So that's a great resource for you all. Furthermore, there's a CME accredited case conference series, UW Telepain. And then another wonderful program is the University of Washington Psychiatry Grand Rounds, and there's an archive with all the previous lectures. That also exists for neurology Grand Rounds. When you are talking about a case or asking a question, remember, please not to ever reveal any PHI. Private health information is indeed private. All sessions are recorded. They're available on our website. And please do complete the 1-minute post-session survey so that we can continue to iterate and improve and have better impact and value for you all. As we said, there's accreditation through School of Medicine for CME. We have no disclosures today, neither the planners nor the speaker nor anyone. And were there ever any financial relationships to disclose, they would in fact be, and then of course they would also be further mitigated. You see our range of institutions and our hub team smiling at you, both on the screen and here on this screen. And wow, I like this new slide. We've provided over 1,700 instructional hours since the inception during the pandemic in June of 2020, a while back. And in 2023, 100% of respondents reported Project Echo Dementia improved their quality of care for patients with dementia, and nearly 64% reported transformation or changes by others within their organization based upon participation in Project Echo Dementia. We have 96 sites representing 250 zip codes and 243 providers who participated. And the best way really to continue to grow this community, well, there are many ways, of course, but one of the best ways certainly is organically sharing with one another, planting seeds. So if you see the value in this, please do share with your colleagues if you think that they would also be interested or could potentially benefit. As we said, we don't have a formal case presentation, but there's going to be lots of time for conversation. And I can imagine that you're going to have many questions for Dr. Jayadev. And also in the future, please do bring your cases forward. No case is too simple. We love cases that have been presented previously, and you can update us. So do reach out to Sammy or, in the chat if you have a case. It's a great way for us to all learn together. And without further ado, as I said, we're super fortunate to have Dr. Suman Jayadev here to speak with us today about neurogenetics and clinical care. And she directs the Neurogenetics Clinic and also the Huntington's Disease Center for Excellence at the University of Washington, rocking her purple in the picture. Thank you very much, Sumi. And I will stop my share. And thanks again.
Thank you. Thank you, everyone, for having me. And I'll tell you, it's so funny, that picture. I'm actually wearing a gray sweater, but through technology, they made it look like I was wearing all purple. So let's see, I'm going to try and move this here so I can see your faces as well. So I'm going to be talking about neurogenetics just sort of broadly. I did bring a couple of cases to discuss as well, but if people have any questions or thoughts or something, they realize, oh, I had this one case, just pipe up. I don't know if you are formally have to go through the chat, but I'm here to talk about anything because this is a pretty fluid topic. So, and then learning objectives, understand key terms, understand implications of test results, and describe different methods of genetic testing, when to use them. Okay, so just to remind everyone, because you may not spend a lot of time thinking about chromosomes very often, but to remind everyone, we have 23 chromosomes, and they're sitting there in the nucleus, but we also have mitochondrial genome, which has its own set of genes. This becomes important, obviously, when we're doing genetic testing, because sometimes there are mitochondrial diseases that you want to be evaluating for. And in that case, if they are on the mitochondrial genome, you have to think about that when you think about which test to send. And so within that DNA, there are the nucleotides A, C, T, and G, and they're paired together. And this is the code that we read when we do the genetic testing. Now, when we get the testing, what we're doing is we're seeing the sequence of the DNA itself, and that DNA then codes for different parts of proteins. They code for amino acids, and the amino acids grow off this machinery during translation and eventually forms a large polypeptide chain, which I represent here. So, the DNA codes for a strand of RNA, which then eventually codes for these immunopeptides. And when we think about mutations or changes to the DNA that cause disease, we're often thinking about either deletions of nucleotides. And in this picture, there's just one nucleotide, but you may have seen in genetic testing results or otherwise that there can be more than one deletion. It matters if it's in increments of 3, because, for instance, if you have 3 nucleotides that are deleted, then you actually have an in-frame deletion. For instance, if you just have this A deleted, then the reading frame changes, and you actually probably likely very eventually end up having a stop codon, and so that affects the whole protein. If you delete these 3 at a time, then the reading frame is saved, and you just actually end up deleting an entire amino acid. So anyway, so there can be deletions. There can also be insertions with the same principle, that if you stay within the reading frame, then the protein itself just gets bigger. But if it's inserted either, not in increments of 3, then you can change the reading frame. Substitutions are what we will lead to, what can lead to missense variants, which means that there is, instead of one amino acid, there's another amino acid. So when we think about testing, this is the gross outline, is that we think about what test, and then we select a lab. And the selection of labs is related to a couple things. One is that how interpretable have their results been. Some labs will say, nothing found and leave it at that. Some labs will say, oh, we found these 3 variants of unknown significance. We don't really know what it means. And then other labs will actually have someone that you can call and talk to. So there are differences in the way labs give reports out. Some labs will do pre-authorization for you, or at least do some degree of working with insurance before doing the testing, and that can be helpful. Not surprisingly, the really big mega labs like GeneDx can be helpful for that, and they can sometimes eat the cost if the cost of the patient is going to be too much in various situations. So we select the lab, and then we do the testing, disclose the results, and then talk about how it affects, or how it incorporates into the patient's clinical plan and life plan. So what do we all want from genetic testing? And I say that because we have interest in doing genetic testing as clinicians, which includes things like diagnosis, treatment, in some cases. Obviously, for our neurodegenerative diseases, we generally don't have a treatment, but sometimes based upon the gene mutation, they may qualify for certain clinical trials. And so it's still, relevant to their management in that way. And then also it helps us understand the disease. From the patient's perspective, they're thinking about, like, what do I have? Same thing as diagnosis. And then they also want to know often, how is this going to help me if I know this information? And then how is it going to affect my life, job, and insurance? And then what about my family? And that, those aren't necessarily harmonized, those 2 interests. And so we find, and it's the case, that many individuals that are at risk for genetic diseases don't necessarily want to get tested, even though we might think it might help with the diagnosis or might help us understand the disease. From the patient's perspective, they don't think it's helpful. And so when we eventually talk to them about it, they often choose not to test. Which I say, I bring this up because I found it surprising when I learned that, because I would have assumed that if anyone, if you're at risk for genetic disease, wouldn't you just want to know? And it turns out that most people don't want to know. So there are important implications to genetic testing. And for the patient, it's about, their health, their diagnosis, their clinical trial eligibility. But then there are important implications to the family. One of them is paternity, non-paternity. And so sometimes not sometimes, but, rarely, or genetic testing will reveal something that clues the family into the fact that who we thought was the father was not the father, et cetera. And so that is an unexpected finding sometimes. You can also find out things like consanguinity, and or other. We had a case where there's a girl that had a progressive ataxia, and then when we did the testing, it turns out that she actually had so many regions of homozygosity that it was clear that she was a product of incest. And then for the family, there can be other more common issues, like there are psychosocial issues, with finding out that there is this hereditary degenerative disease in the family that they didn't know about. And then it also has implications for the family with regard to their family planning, in terms of doing prenatal testing or IVF, that sort of thing. So this is why we have a whole field of genetic counseling, and I'm glad to say that we finally have a genetic counseling program at the UW. It's, I think, maybe 3 years old at this point. And so they have a specialized set of training. They get a master's degree. And from our standpoint, it's important because even in late onset diseases, it still has relevance, like we were just talking about, to so many other people. And when they sit down with patients, they talk about what are the patient's perceived risks and benefits to testing. The counselors are the ones that talk to to families about all the issues I was just mentioning in the previous slides. They also explain a bit about the biology too. So they get into things like inheritance and penetrance, and which helps not only patients to understand the disease that they're being tested, but it also gives them a sense of, it allows them to think about how they want to think about risk to their kids, et cetera. And then the genetic counselor meets with them, and then they may or may not do testing. And the counselor also is there to do the results visits, which can often be very challenging. And we believe that for predictive testing, meaning when you're testing someone for a gene variant, but they're asymptomatic, we feel pretty strongly that genetic counseling is necessary. All that said, there are not enough genetic counselors out there right now. And so because of that, and I think also because of COVID, there have been some pretty good online alternatives where these are licensed genetic counselors that work that work in the same sort of format as we do. They'll meet with patients before testing, they'll meet with patients after testing. And so it's something that we do try and remind people of that are not, sort of in a urban area where they have, hospitals with, large teams. So it's been something that a couple of our folks that are out in more rural areas have taken advantage of, and it's been good for them. So a couple other points that we talk about with patients is now the right time to test. So sometimes people come to get testing because they found out 6 months ago that they had, FTD in the family, and they said, okay, now I better get signed up for testing. So then we say, is now the right time? Do you need to know this now? So are you just about to start a new job, or are you in the middle of a divorce? Is there any reason why we should think about just waiting for a couple months or 6 months? Not, that's not always the case, but it's good to check in. Because sometimes people just assume that now that they're at risk for something, they should just get tested. For other diseases like FTD or Huntington's, or other life-limiting diseases, especially when there can be psychiatric components to it, we also do ask in the beginning before doing any testing, do if they have counseling, do they have a history of suicidality, any of the other psych stuff, and then try and make sure they have some support people or some plan. We tell people that we don't necessarily get clear black and white answers. So if we know something's positive and it's been reported before, great. If we see nothing on that test, great. But sometimes, or usually, we find some variants that are uncertain. And so we share with patients that we may find something that we can't really interpret yet. And in those cases, we say, we'll just follow up with you every couple of years, for people that we feel like there probably is a genetic cause. And we see if science learns more, and then we can update you on that specific variant, or if there's other testing to be done, et cetera. But just for them to know that there may be uncertain things that we get. Also, we might, for certain types of tests, so if you were to do an exome, for example, patients can opt in to learn if there is something actionable that is found on the exome. For instance, if they're at risk for cardiac, like sudden cardiac death genes, patients can opt in to learn if they're at risk for that, or cancer genes. And so when you do testing like that, they may find information about some of those syndromes that may be unexpected but medically important. And then we want the patients to think about the following: is how is the testing going to influence their relationship? Is there anything that they need to think about when they talk about results with their family? What are their personal coping strategies? What's their support network? And then how is the testing going to influence their short and long-term plans, their family planning, career? And then lastly, what sort of financial planning should be done prior to testing? And that last bullet, I think, is an important one. That's where we feel like we come into play as the clinical team. And so important things that we let people know is that health insurance and employment are protected by federal law, by an act called GINA, which I'll tell you about. However, long-term disability life insurance is not protected. And when I say protected, I mean not if you have a clinical disease, but if you have a gene test that's positive. So if you're gene positive for a disease, your health insurance is protected, but not your access to disability and long-term health insurance. And so GINA is the Genetic Information Non-Discrimination Act, passed in 2008 under the Bush administration. And it protects people from being discriminated against. And so that's an important, and hopefully that stays. There is a website at NHGRI for anyone who's interested in learning more about it, if patients want to know more about it. There is another act that's important for us to know, and probably more timely now, which is called the Cures Act, which you all may know about. And so the purpose of that act was to supposedly accelerate the delivery of 21st century cures. But along with that came this rule that was meant to sort of empower patients so that they would get whatever information that we had, that we would not prevent them from knowing any information. And so that included genetic test results, which means that, so prior to that, we would do genetic testing, you'd get the result, and then you would tell the patient when you had that meeting with them. But now those results are in Epic. And so we've had a case where someone had their Huntington's testing out somewhere else, and that lab result went right into Epic before even getting to the clinician, or at least before the clinician, had it in his box, or, could look at it. And so the patient found out first just by opening their chart. And so that is obviously not an optimal way to get your test results. And so there are ways that we as providers can actually try and mitigate that. And so there are exceptions to that rule. And one of them is preventing harm. And so under that, so these are all different formal rules. So under that caveat of preventing harm, you can actually ask to hold the results from the chart and the patient until you meet with them in person. They have to agree to that, by the way. So if anyone wants more additional resources about genetic counseling, there are contract genetic counseling, like I said, that through Genome Medical, and then there's a Genetic Support Foundation. And then some of the commercial labs that offer genetic testing do have genetic counselors. I'm not sure about how, I'm not sure about the people's experiences with that type of counseling, but they are available. So if you're in a place where you just don't have any other, if there are no other resources, that's something that you can look into when you're picking a lab, say, and see if there's any genetic counseling with that lab. Anyone have any questions about counseling and all that? Okay. So here is a case. So I had we had a 59-year-old woman who awoke with hemi-body tingling. So side of her body was feeling funny. She didn't have any weakness. She had no cognitive change, but she did have some headache, and she had some visual changes. So she went to the hospital. She got admitted for a stroke workup, and they did the full stroke workup. So she had vessel imaging that was negative. She had an echocardiogram that was negative. She really had no other reason to be having this stroke, but her MRI had bilateral patchy subcortical white matter changes that looked like small vessel disease, but she had no history of smoking or diabetes. Her blood pressure in general has always been normal, if not a little low. And so she was started on 325 milligram aspirin a day for prevention. So this is her pedigree. So the gal we're talking about is here in this brown arrow. And so she was 59 when I met her, so fairly, young. But she had this quite impressive history of stroke in her family. So she had a number of cousins that had early onset stroke some in their late 30s, 50s. And these folks have all passed. We didn't have any information on them, but pretty impressive pedigree of what looks to be autosomal dominant disease. Certainly could still be X-linked disease, this doesn't, this pedigree doesn't tell you that either way, but certainly genetic. This is what her MRI looked like. And so there are a couple of things to note here. Here in her anterior temporal lobes, there are these white matter changes, and a lot of subcortical damage, as well as what looks like to be external capsule involvement of the white matter. So the diagnosis that's often considered here, so by the way, she had a diagnosis of CADASIL. And so the diagnosis that is often considered when we have patients that are referred for this disease is multiple sclerosis. And so we've had, you'll get patients that that supposedly have a family history of multiple sclerosis. So that's one clue. And then there are other genetic forms of disease or other genetic forms of cerebral vascular disease that can sometimes look like the image that you just saw. So one of them are collagen connective tissue disease, collagen 4A1 and 2 mutations. Those are autosomal dominant. Carousel, which is a recessive form of CADASIL. And then this one, TREX1, is an interesting syndrome. It causes small white matter. It causes small vessel disease. But it also can sometimes look like there's tumors. So we've also had cases where patients have had a family history of glioblastoma because no one had ever, they didn't get an autopsy and maybe they got some imaging and that was it. But this is like a vascular genetic disease. And then some other more rare diseases. But CADASIL, which is a mouthful, autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy, genetic small vessel disease, is autosomal dominant. It is, it's nearly 100% penetrant, but I pause for a second because we know a lot more about this disease now than when we did a few years ago when a number of these large cases or these large reports about phenotyping were put out. I think it's clear now that there are individuals that do okay into their later decades and without having any significant change to their function. But typically it's early onset stroke, so in the 40s to 50s. With TIAs, they can often start with migraines earlier in life, sometimes even in teenage years. And then later on, by the time they're in their 70s, most or more than half people will have dementia. And it's what you'd expect. It's an executive type of vascular dementia. These are better pictures of sort of the canonical images of CADASIL, these anterior temporal lobe abnormalities and the external capsule changes. Now, the anterior temporal lobe changes are not unique to CADASIL. So even like myotonic dystrophy can have those changes, type 1. And of course, external capsule and this pattern of small vessel disease is pretty nonspecific. So the variants in CADASIL are interesting. They're sort of, they follow a particular pattern, which has really helped us understand to some degree the mechanism of disease, but definitely helps us to interpret the test results. And so the protein that's encoded by Notch3, and Notch3 is the gene associated with CADASIL. The protein called Notch3 sits on the membrane of the cell. So here's my little cartoon of a cell. And the extracellular part of the protein has a number of these EGF repeat domains. These are all little parts of the protein. In each of these domains, there are 6 cysteine residues. And they all, they form disulfide bonds, the 2 cysteines. And so what happens is that in each of these domains, you have cysteines that form bonds, which helps create the structure of the protein. And here's an example of, so here's how within this loop, these 2 cysteines form. Mutations in Notch3 that involve a cysteine cause CADASIL. And nearly all of CADASIL-associated mutations in Notch3 involve a cysteine. The idea being that if you lose or gain one of these cysteines, you disrupt the formation of the protein, the structure of the protein. So here's an example of a test result we got for a patient where what we found, so the gene is here, NOSH3, and they tell you the variant. The protein structure is that instead of a cysteine, you have a tyrosine, and the person is heterozygous for it. The lab called it likely pathogenic. And what it said is that it has not been reported in association with disease or large population databases. So really, it hasn't been reported before, but is predicted to disrupt a cysteine, and cysteines are important for disease. So based upon that, they said likely pathogenic. But what I wanted to point out is that here is another lab that had another similar situation where we knew that we had a patient that looked very much like CADASIL. And then when they got this gene mutation, or when they got the test results, it said it was a glycine to cysteine, again involving a cysteine, and yet they called it uncertain significance. And their rationale was that it is also not present in the population database. In fact, this lab had found this mutation previously reported in patients with CADASIL, but they still thought that the available as evidence was not sufficient to determine this being pathogenic. So I bring this up to demonstrate sort of the variability in which labs will interpret what we would think to be pretty strong evidence that something is pathogenic, and it goes both ways. So sometimes they might call something likely pathogenic, and you're not exactly sure. So when you get test results, it's worth just going through and asking yourself if it makes clinical sense or not, and look through the rest of the test report, because there will be details on that report that can be helpful. And so this is what, oops, okay. So I guess what I wanted to point out here is that this is the spectrum of classifications that you will get from a test result. And many labs don't even report the ones that are benign or likely benign. And this is this huge sort of matrix that labs use, that the field uses to annotate if a variant is pathogenic or not pathogenic. So they look at all, and so this is, you don't have to read the little part here, but I want to just point out, this is the type of data that we look at to determine if something is probably disease related or not. So one is the population data. So how frequent is it? If we're talking about something that's autosomal dominant, or we suspect to be autosomal dominant, we expect it to be rare. So if it's reported in the general population at some frequency, we generally don't think it's pathogenic. And then there's computational models, and these are constantly growing. And so these are models that predict that the way the protein should fold, or the way the function might be impaired given the mutation. Functional data. So in some cases, there is cell in vitro work that's done to look at the effect of the mutation. And sometimes that can help with annotation. The big problem there, especially for neurodegenerative diseases, is that what is the in vitro assay that you're actually doing? I don't think we even know what we should be assaying in the first place. We probably don't even have the right cells. We don't have cells that are 70 years old when we're doing these experiments. And so I think the functional data from our perspective is a little iffy, but anyway, it's an important part of trying to tease apart the impact of a genetic variation just in general. Segregation is one that we can do, which is how does that mutation travel with the clinical phenotype in the family? And that's, when you have the luxury of having multiple generations, you can ask that question. And then there are some other pieces, but those are the main ones. Another piece of information that we think is important for talking about test results is the idea of penetrance. And so there are gene variants that you will get that aren't completely penetrant. So when you tell a patient that yes, your disease is caused by this mutation, what does it mean for your kids becomes a little more difficult. So it's always good to be aware of that when you're talking about results to patients. What do we know? What do we know about that mutation? with Huntington's is probably the one that we see regularly, and that's because the mutation in that gene, if you recall, is not a switch or not a deletion, but a duplication, or not even duplication, but an expansion of a repeated sequence of CAG. And so in the normal allele, there's between 10 and 30 or so of these CAGs, but when it expands into something larger, it can cause disease. And so when it's 40 repeats or larger, people will always have Huntington's disease. When it's between 36 and 39 repeats, we call it reduced penetrance. And so that's an example where someone might have 37 and they might get pre-symptomatic testing and they'll have 37 repeats. And we say, not sure if you're going to get disease, but we know that you shouldn't have a rock and roll lifestyle, exercise, and that should hopefully, keep your brain healthier than it would have been otherwise. Other pieces, other important pieces of information that may not necessarily come up for you when you're giving results, but has come up when people read their own test results, is this idea of pleiotropy, that variants in the same gene can cause different phenotypes. And so the classic one from the neuro perspective is the calcium channel, the CACNA1 gene, where missense mutations can cause hemiplegic migraine. It can also cause episodic ataxia, but expansion of a CAG region within that gene, same gene, can cause spinocerebellar ataxia. Very interesting. Prion diseases are the same thing. So mutations, and there's a pretty interesting genotype-phenotype correlation. Certain mutations in that one gene can cause a phenotype that looks more like dementia, and then other mutations look just like CJD. And then there's the concept of variable expressivity. And so this is the idea that even in the same mutation, often in the same family, you don't have the disease presenting the same way. And FTD ALS is probably the most relevant one for us. And so this is a pedigree of a family that has the C9orf72 expansion. And so everyone's a diamond here because they're just the sexes eliminated for sake of privacy. People that had ALS are in blue, people that had FTD are in brown, and then there's some people that have both. They all had the same, chunk of DNA they inherited, and yet they manifest it differently. So here's a case of a 67-year-old. He had 1-year history of gait instability after a fall. He was fine until then. He didn't have any concerns for weakness. He had no changes to his cognition, no changes to his vision, no psychiatric changes. He really didn't have much of a medical history. He had just retired recently, just to retire because he was 67. And he was referred to us because he had a family history of ataxia. And because he had this gait instability, the question was, does he ataxic? So on exam, he just had some increased tone on his arm, but he didn't really look ataxic. He had good 5 out of 5 strength. He may have had an upgoing toe on the right, but otherwise his cerebellar exam was totally normal, and his MRI was unremarkable. So if we look at his pedigree, this is what it looked like. So we call him, he had some form of spasticity. He had just had this increased tone. And his mother, turned out, had this diagnosis of spinocerebellar ataxia. And she had actually been seen at the UW Neurology Clinic many years ago and had been given that diagnosis of SCA. There was also a question in those notes that maybe her mother had a diagnosis of ALS, but they weren't sure. And so we hear that and we think, okay, well, maybe it was just ataxia and the SCA, and they thought it was ALS because there's no real good details. So his brother had a diagnosis of ataxia for 6 years. And that brother had signs of cerebellar atrophy and cerebellar ataxia. So it really looked like a family history of ataxia. And so the question becomes, well, what to test for this fellow who had increased tone and a family history of ataxia? So his brother had already been tested for a bunch of ataxia genes, which included the C9orf72, a 300 gene movement disorder panel, and then he had gotten SCA1 and SCA3 a year earlier. Those are autosomal dominant ataxia syndromes. Those are all negative. So when we met the person, we said, well, let's get, additional repeat diseases. I'm kind of going off a little bit tangent here so when I say repeat expansion panels, is because some of these ataxias, which are cerebellar diseases, are caused by that same type of repeat phenomenon that I was talking about with Huntington's disease. And the reason why that's relevant for testing is that on the typical type of panel that's based on using exome next generation sequencing, you're not going to capture these repeat expansions. So you have to test them separately. So between our patient and his brother, they had all that could be tested really for ataxias at that time. So we said, well, come back and see us in a year. But he was referred to neuromuscular because of his spasticity. And they had been following him. And then he comes back to us 2 years later. And so now he has bilateral lower extremity weakness, right worse than left. He's hyperreflexic everywhere, and he has upgoing toes bilaterally. And an EMG at that time showed chronic denervation with reinnervation, and a diagnosis of ALS was made. So we then, actually, no, we didn't. His neuromuscular doc then sent for an ALS panel, and that panel showed that he had a pathogenic variant in TBK1, and which is predicted to alter splicing and expression of protein. So he had this variant, and they actually didn't call it pathogenic. It was just a variant. He had it. And so the question is, well, is that what about the rest of the family? And also at that time, it turned out that he had a sister who had cognitive problems that no one really wanted to talk about because she was odd. So we got testing on the rest of the family, and his brother had it, his sister had it. So we showed segregation with the disease. And sorry, their unaffected brother did not have the mutation. So what this family had then was a TBK1 associated FTD and motor neuron disease syndrome. And what we found is that they also had an ataxia. And it turns out that TBK1 mutations can cause a broad spectrum of things, which includes cortical basal syndrome, aphasia, ataxia, Parkinsonism, along with the ALS and the FTD. And it is one of these, it's a TDP43 pathology associated disease, but quite varied in clinical phenotype. And it's a reminder of how varied this FTD ALS spectrum can be, or how many points along the spectrum one can be. So these are the genes that we typically think of when we think about ALS and FTD, and then the many genes that actually can cause both ALS and FTD, even in the same family. What underlies the similarity in these syndromes is the big billion-dollar question, but it's interesting nonetheless, and there clearly are clues hidden in these people. Okay, so if you're thinking about testing for FTD, things to know are that maybe up to 10% of people that are sporadic and have behavioral variant FTD will actually have a pathogenic variant in one of the FTD genes. And sporadic means they don't have a clear family history of FTD. Now, that's always a difficult thing to assess in late onset neurodegenerative disease, because oftentimes, especially in older people, the generation above them didn't necessarily live, to their 90s all the time. 10 to 17% of sporadic ALS will have some pathogenic or likely pathogenic, and half of those are C9orf72 mutations. And then within familial FTD and ALS, C9orf72 is the most common cause. So if we find someone that we really think has a genetic disease, but we had genetic testing was negative, we ask them to come back every 1 to 2 years and see what can be done. Because as you can see from this case, from the original testing panel, it was negative, but within a couple years, so many new genes had been found, and then that's when we were able to catch it, because the panels have been expanded. So the take homes from this is that confirming the variant segregates is an important way of trying to figure out if something's pathogenic, and that to think about how the testing landscape changes. I'm going to pause here because I don't know how much time I have. Does anyone have any?
You have time, assuming.
I have time. Okay. So so that's like, clinically relevant stuff. I just thought I'd throw in a few more comments about sort of not clinically relevant stuff, or at least not clinically relevant stuff right now, which is when we think about genetics of AD, of Alzheimer's disease, how do we think about it? And so, we do talk about sporadic Alzheimer's disease and familial Alzheimer's disease. And then, of course, there are people, many people that, and there's evidence to suggest that even sporadic Alzheimer's disease, of course, has some genetic component. And what is that genetic component? And probably why does it matter? And I think the way I think about it is that the genetic component just gives you clues about what might be contributing to the process. So one of the ways in which studying the late onset form of Alzheimer's disease has given us insight into the mechanism has been, or one of the ways that genetics has helped understand the disease is by leveraging the fact that we do have this genetic variation, and it has allowed us to start to hone in on parts of the genome that seem to be relevant to your risk for Alzheimer's disease. And so, we started down this genome-wide association study many years ago, and at that time, people thought, aha, now we can survey all 3 billion, or at least, regions across 3 billion base pairs in the genome, and we're going to find the answer to all these diseases. And it turned out not to be true, probably for many, many reasons. But the GWAS have actually been somewhat helpful. And so just a reminder that with genome-wide association studies, what they're doing is looking at these single nucleotide polymorphisms. So instead of a G in this position, you might have a T. And when we say polymorphisms, it's because that means that they are somewhat frequent in the population. So they happen more than 1%. So, all of us on the call, 20% of us might have a G, 80% of us might have a T, or, a few might have something else. So this variability is what gets capitalized on for the GWAS. And so using the GWAS is where you genotype people across those SNPs, where there's variability in the general population. You can then see statistically, if you have tens of thousands of people, which of those SNPs are statistically correlated with having your disease of interest. And then that can bring you into a certain, a locus on the chromosome. And so here's the Manhattan plot, where the plot is actually of the p-values, the statistical significance, and each of these little dots are one of those SNPs. And within the SNP labels a chunk of DNA, and within that chunk of DNA are a number of genes. And so some of those genes may be particularly interesting, and so people think, okay, well, this SNP is likely related to regulating this gene because it's in the region. And so by making these associations, the field has started to pick apart what they think are relevant pathways, given that the genes in these statistically significantly associated regions are present. So when we map out all the different pathways that the genes in those risk loci represent, it turns out to be quite heterogeneous or quite diverse. And so here on this is a little X and Y axis of genetic variants associated with Alzheimer's disease. So on the Y axis is the degree of risk that the variant causes. And on the X axis is the frequency of that genetic risk. So when we're talking about autosomal dominant, very rare Alzheimer's disease, they almost always cause Alzheimer's disease. And so they're really high up there on the effect size, but they're excessively rare. So they're very low. On the other hand, so you have something like ApoE, which is sort of common, and has some middle effect. And then over here on the far right, lower region are the genes that are represented by SNPs. And so the thing to note here is that they are quite common. 30 to 50% or even more of the population have them, but they're very low risk. So the odds ratio of having of each of these is like 1.05 or something, or 1.1. They're pretty low. The idea being that it's the aggregate burden of all that risk that tips you over the edge to having Alzheimer's disease. But they don't all do the same thing. And so one question has been, are there different pathways to Alzheimer's disease? And so people have talked about that. Is it all the same disease or not? Especially given that we make the diagnosis based upon the pathology of two proteins. Certainly clinically, they, classical Alzheimer's disease, or that, there is a typical phenotype for Alzheimer's disease that distinguishes it from other types of dementias. But there may be different ways in which the biology takes you to that same place. And so that's been one area of interest for a lot of people. I think that was actually what I want to talk about there. The other piece about the common variants in the SNPs is that there have been questions about polygenic risk scores and whether or not we can use them in the clinic. And I think there had been a time where we thought, okay, we're going to get everyone's polygenic risk. We're going to use that in our, in our matrix of general risk for developing disease, so that when you come in and you're 50, you can find out what you're at risk for. And now we know that that's not going to be very useful for a number of reasons. One big reason being that all of the studies of genome-wide association studies have been done on the essentially European white population. And so because there's genetic differences between different populations, those polygenic risk scores based on those GWASs are really mostly relevant for them. And there have been studies to look at how accurate those polygenic risk scores are when you go from population to population, and they get and they can be quite poor. Furthermore, the math of creating a polygenic risk score matters, and the correlation between different ways in which you generate a polygenic risk score is not good either. So, so that has a long way to go before that becomes clinically useful. Okay. Well, that was sort of my collection of topics.
Wow, Sumi, thank you so much. You covered a very, very broad range of topics, and I'm sure there's lots of questions. So I'll open it up to the community, and people can either unmute themselves, or you can stop the share too. Yeah, great. And people can unmute themselves or throw it in the chat. Christina, did you raise your hand? Did I see?
I did, but I'm happy to wait. Christina, great. You can go ahead if you had a question.
No, I just unmuted to say I did not, but I saw that you did, Kimiko. So go ahead.
Oh, Kimmy, thanks.
Yeah, Sumi, I was wondering, you talking about how, just the technology, everything keeps changing, new discoveries. Also wondering about logistics of, seeing people all across the state and help, because genetic counseling is hard to get to.
Yeah.
And it seems like sometimes there's the ability to do cheek swabs, and facilitating, getting a test kit. Could you talk a little bit about, blood draw versus cheek swab and how we might reach people who maybe can't travel all the way to Seattle to see you?
Yeah, that's a great point and question. So so now what is possible is that they can get DNA samples either from saliva or from cheek swabs, which means, like Kimmy's saying, that we often will send out a kit to people. So so that would mean, we would meet them for counseling, and if they want to do testing, we would just have the kit mailed to them from the company. They get the kit, they do the cheek swab, they put it back in the mail, and then to the company, and then we get the results. And so that's how we do many tests. That is usually when we've seen them for one, either before or after. We'll either see them pre-test or when they come back for the results. But of course, that isn't always possible. And I would say if for people that have a relationship with their patients, and that's a good way of to go. I mean, it's a reasonable way to go, is to just have the test sent to them rather than them having to go someplace to get blood work. Similarly, if they wanted to do that and then get genetic counseling through one of these services, that's also another way to go too, because they do that by Zoom. We've had, so for the Huntington's folks, we are trying to arrange where we can do some counseling and then they go see one of the movement disorder docs in Spokane, as a way so that someone actually has sort of like hands-on someone before you say whether or not you should get Huntington's testing, because we want to have a good reason to do it. But it'd be nice. It certainly would be a great thing, I think, to work with folks in different parts of the state. If they wanted to see patients together like that, we would be interested in doing that too.
Thanks, Kimmy. That was a great question. And I'm curious from both of you, and in my experience, I mean, you talked about the cheek swab. I think that it's very hard for patients to send the saliva, and we often don't get any results with that. So I don't know if you want to weigh in on preferentially encouraging the cheek swab if you are doing those send out kits. Sometimes it's hard for people to get the saliva in the. Is that your?
I guess. Yeah, no, we've been. They have been cheek swabs recently.
Just so for people who are
going
to get those kits, because just to make clear.
It's a good point. Yeah, it's a good point. Since they can do the cheek swabs, it's easier, and then someone else can do it for them as well, which you can't do with the saliva.
Reza, thanks. Reza?
Hi, we get some handouts from the drug reps about the psychotic test for the medication, basically the psychotropic medications. And they really promote it and say that Medicare pays for that. I haven't used them actually, but I know some people they use. I would like to know what you think about it. Thank you.
Yeah, no, I've never used them either. I don't know much about how helpful it is for the clinical use. So I can't comment about that. My experiences with my folks has been that you just keep trying different ones. So yeah, I'm not as elegant as a antipsychotic prescriber, I suppose, as I'd like to be.
Thanks.
Carrie?
Yeah, hi, thanks for your talk today. We're going to start seeing a lot more ApoE genotyping right? And especially as the monoclonal antibody therapies become more frequently used, and some of this testing may possibly reach primary care. In your opinion, do all folks who get ApoE genotyping need genetic counseling? And
Counseling.
if so, that's going to slow down a very cumbersome and slow process even more.
Yeah. I mean, I think so. If you're talking about for the treatment, at least what you have are people that are already affected. So testing them in the affected cases is okay. What may happen is that then they're going to say, what about my son, who's at 50? And then that you don't need to, you don't have to, I don't know, actually, if you guys even have a plan for what you say about that in our clinic, except that, what I would say is that, we don't know very much yet about what it means, and the numbers for your risk of ApoE4 are quite wide in terms of the, what your actual chance of getting Alzheimer's disease are. And but otherwise, I don't think that you need to necessarily, I mean, I think it's good to be able to be prepared to say that if they do have ApoE4 and then they start asking you, what does this mean for my kids, that you can just say that they're at 50% risk of getting it, and go from there. We did actually see someone the other day who was 4/4, and the visit was purely just to talk about what they're going to say to their kids. So it's not unreasonable just to have an appointment with a genetic counselor for that sake, but I would say that's an appointment for a genetic counselor. You can make those referrals.
Nancy, any other thoughts just in terms of preparing
Well-
both institutions and primary care for this?
Yeah, no, I mean, I think to follow up on what Sumi just said in terms of working with a genetic counselor for the first degree relatives, and also that there is epigenetic modification. So it's important in that context to speak about the things that people can do that have an impact on their, disease progression, natural history, quality of life.
Yeah.
Very important. In terms of, so at Swedish, we do testing for ApoE4 genotyping, apolipoprotein E genotyping for everybody who has MCI due to AD or mild AD who's being considered for monoclonal antibody therapy with lecanemab and soon donanemab. Because as people here have, are aware, if you have 2 copies of the ApoE4 gene, your risk for the amyloid-related imaging abnormalities, the bleeding and the swelling in the brain, is significantly increased compared to those who have 0 or even 1 copy of the apolipoprotein E4. And so therefore, in our discussions about risks and benefits, and I know that that's what you are all doing as well in terms of the monoclonal antibody safety and eligibility process at UW as well. And so in that instance, definitely, I think you have to know because it impacts decision-making. But I know Mimi has a question about what if somebody comes to you with a 23andMe, here's my profile, I'm 40, I'm fine, and I've got 2 copies, I'm 4/4, what to do, and how can we clinicians, work with that? So
Yeah.
Mimi, do you want to ask your question or share your comment?
No, thank you, Nancy, and thank you, Sumi, for this great presentation. I'm just curious, if people do find something on the 23andMe testing and then come and want additional testing, does that require genetic counseling? And what I'm really curious about is, does insurance pay for that?
Right. So there is some insurances pay for genetic counseling. And that is possible. Otherwise, if insurance doesn't pay for genetic counseling, then it comes with the MD's visit. And that's how they get their counseling. I mean, I do think for ApoE, counseling would be important just because it's so hairy and murky, that it's useful for patients to really think about, you know, what does it realistically mean for me? And what does it mean if it's, you know, tenfold risk, but actually what we're talking about is still, you know, whatever, 20% by the time you're 80, all those weird you know, all those numbers that when you think about it in a different way, you realize, okay, it's a couple times higher, but if my risk was really low in the first place, then what does that mean? So
you.
yeah, I would say genetic counseling is useful for that.
Toby?
Yes, well, you kind of partially answered with your question about someone with ApoE4, but I wanted to ask about, like, if you have like a family or even like a patient with ALS, FTD that was also already diagnosed, and you know you are doing this kind of counseling for like their young children, or I mean, and so what is your approach? Or okay, you're giving like percentage of what is the risk for them to become, or what is the penetration, or do you also kind of give some guidelines or practical kind of okay, what to do, like when you say to prevent, I mean, if you have, I don't know, 20%, how you can reduce it? So that's my question. What do you tell to the family or the like the offspring of the patient that are still very young in their 20s and they just got this bad news?
Yeah, that and they've had the testing or they haven't had the testing. That
So one of their family, like one of the parents was diagnosed with
Yeah.
one of the gene with ALS or FTD. I especially know one that just diagnosed with ALS and she went to genetic counseling and got that she's carrying this mutation for ALS FTD. So, and she has two boys around their 20s. So I'm just kind of curious because I asked you, what are you going to do? So what is your approach? What to do? Because it's really bad news. It's so stressful, and
it is
Yeah.
so stressful, and there's probably the one thing that's more stressful about getting the diagnosis is knowing that your kids are at risk for it. So it's
Mhm.
a horrible part of it. So what we say, so first of all, so if someone is diagnosed with a genetic disease and they, you know, they have the diagnosis and they have kids, like less than 18, what we tell them is that right now we say, if it's not actually affecting them clinically, we would recommend to wait until they're 18 at least. I mean, in reality, a lot longer, so that they can make those decisions for themselves, number one, and number two, they don't have that genetic diagnosis on their, you know, on their record for if this country goes sideways and all of a sudden your genetics make a difference. But you've got 23-year-olds who are about to have kids and they say, what am I going to tell my kids? So what we say is that the reasons why people come to get genetic testing are often because they're about to start having families, or they're worried about, you know, whether they're having symptoms. So we say, you know, you can share with them that they're at risk for this disease. And if they'd like to learn more, we're happy to talk to them. If those kids come to see us, we say, you know, your risk is 50-50. I mean, most of these diseases are really nearly 100% penetrant, the ones that we're talking about. You're at risk for getting this disease. Let's say they decide to test and they're positive. Then we say, you know, here's the, you know, there's animal data to support that if you make animal models of neurodegenerative disease and you make some of these mice exercise and some of the mice not exercise, the ones that exercise do better. And then if you take these animals, you know, animal models, and you give some a really high fat diet, they do worse than the ones that don't. So there's like biological data to support the fact that if you are cardiovascularly healthy, you're taking care of your brain, that you might do better. There is retrospective data on more patient-reported data about exercise and drugs. So in the Diane group, so in the group that have familial Alzheimer's disease, there's data to suggest that those that were exercising regularly, and that was their self-report, they may have had a slightly younger age to onset, or milder phenotype, younger age to onset than the ones that didn't. So some evidence that they can do something to change their course. On the other side, there is a data, or there's a literature in the Huntington's group, which is a much more mixed group, that the ones that were self-reporting a lot of smoking and alcohol had an earlier age of onset. So, being toxic to your brain did have an earlier age of onset. Being better to your brain does delay onset. So there are some things that people can do. So that's what we tell them. If they're in our office, they've tested positive, or even if they haven't tested and they say, well, what can I do? That's what we tell them. And I feel good that there's biological rationale behind that. We're not just saying, oh, take care of yourself. There are people that, yeah. So that's what we say.
Thank
and
you.
dealing with kids, then it's the counselors have a great way of sort of, the idea being that you let them ask you questions, you sort of have them direct you to say as much as, you think they want to know. They tell you they want to know.
Yeah, it's hard situation.
Yeah. I've had a couple of young people that were just adamant they wanted to get tested, just needed to get tested. And there's one, and they have, more often than not, they have, well, obviously because they're positive, but they have regretted testing, which in hindsight is always easy, but hard to know what that not knowing does to you as well. So
Yeah. Thank you.
Thank you.
I just want to say that, like, I had families with BRCA1 and 2, and I really have a family not here in US, but that was and they tested, and they have really 3 daughters, very young daughter. And even if you go to counseling, you find it, there is kind of guideline, you have something to recommend,
Yeah.
You can do bilateral mastectomy, but in this case, it's so, because even if you exercise, you probably won't prevent the disease, the manifestation and the disease to happen. So
yeah, no, it's really hard. I mean, the one of the saving graces for us has been, we say, well, we have our colleague, Dr. Demoda Riley, who's doing research in this area. And then it gives them knowledge that they can participate in something. And that has been very valuable. To be able to do that. So for, our AD and our Huntington's and FDD people, it's been really valuable to do that. And that's been good. Yeah. Otherwise it's not a lot of other options for now. It's just for now.
Thank you again, Sumi, for this great talk. And thank you all for this really great conversation. And popped in the chat is the survey. Please complete it if you can. Bring your cases forward. Remember to text 10085 for CME, or let Sammy know. And on October 25th, we have sleepiness and fatigue in older patients with Dr. Lena